For factors influencing pain response, of course, we all know everybody interprets and responds to pain in different ways, and there's many factors that can affect that. Physiologic factors include just the way that they are physically feeling that pain. It's very hard to quantify and measure, but some people, just a simple example would be if somebody has possibly had spinal fusion surgery before, so they've had back surgery and they're feeling more pain. Maybe they've had other issues that, cervical scarring or different things that might cause increased pain for them as well. So each person could physiologically have a different amount of pain happening during their labor. Another example would be if the baby is asynclitic, is the term, and it means just a little off in its alignment in the pelvis. Maybe that mom is experiencing more back labor. You get a lot of back labor as well if the baby is sunny side up or occiput posterior, which would be face up at delivery. A lot of back labor in that case too, right? So not every labor is the same, of course. And then other factors could be age. A very young person may not have the coping mechanisms that an older person has. But also all of us have probably seen older people that are not very good at handling pain as well. So age can be a factor, not necessarily, a 1 + 1 = 2 equation there though. And then culture. So different cultures sometimes express pain differently. They might be very stoic or they might be very animated. And these are all generalizations. Every time we talk about culture, this is, broad generalizations. We don't want to assume, but just to kind of be aware. Another possibility is in some cultures, it's rude to accept something the first time it's offered. So what if you only offer something one time and they say no? Well, it may just be because they're trying not to be rude. And then, of course, anxiety and fatigue can really play a part in how pain is perceived. So there is a theory called the fear, tension, pain cycle, and it basically says that the more afraid you are, the more tense you will be, and then the more pain you will feel. So this is this kind of psychological circular thing that happens where if you can decrease your tension through relaxation, or you can decrease your anxiety, your fear, through focus and through possibly breathing techniques and other relaxation techniques, that it will help you manage your pain as well. Previous experience can have an effect on your pain response too, right? So in either direction. If somebody had a positive previous experience, it may be decreasing their anxiety, decreasing their pain with that. But if somebody has had a previous experience that was negative or traumatic, then it might increase their anxiety and perception of pain. So sexual abuse is a good example of this as well. It's not necessarily a previous experience with labor and delivery, but they might have trauma and just be anxious about the whole birth experience because they have mental and possibly even physical trauma, related to anything that has to do with labor, delivery, anything in the vaginal area, cervical exams, exposure and things like that. There is mentioned in your book this gate control theory of pain that's very important for managing your pain non-pharmacologically, because it's at its basic level, it's distraction. And why does distraction work? It's because the theory is that your sensory input into your brain has one gate, and it can only allow one train in at a time, one pathway at a time, and that's either pain or pleasure. Well, if we are blocking, consuming that gate and blocking the path for pain with, let's say we're inundating it with other positive, pleasurable sensations. So it might be relaxing music or a nice smell in the room, maybe a lavender diffusion, maybe positive touch, so this light massage, things like that are positive, relaxing, just good sensory input, then your brain will not perceive pain as strongly because it's blocking that. So that's called the gate control theory of pain. The other thing to mention about that is that it's only good, your brain starts getting used to it after about 20 minutes of whatever method, which is why we have all these different methods of non-pharmacologic pain management, because we need to kind of have a big toolbox, a big arsenal of different things to try, because after 20 minutes, your brain's like, no, that's not interesting anymore, and it starts listening to the pain sensation more than it does that, what it considers an old, pleasurable sensation, okay? Of course, as nurses, we're offering lots of comfort and support to our patients, trying to create a positive environment for them. All this can help have a positive birth experience, help decrease anxiety, and of course, pain as much as we can. I mentioned a few of these non-pharmacologic pain management techniques a few minutes ago, but here's kind of a more comprehensive list. So counter pressure is really great for back pain. You can put pressure right on her tailbone and it can be helpful. You can do a hip squeeze as well and help just kind of relieve the tension on some of those tendons and pressure in the pelvis and back area. And then therapeutic touch and massage. The term for light massage is called effleurage. So if you see that, that's what that means. Ambulation is really good. Any upright position is going to help encourage fetal descent. And then rocking back and forth, position changes for sure. Heat or cold. This could be with a heating pad on the back. You never want to do that on the belly, of course. We don't want to overheat the baby. But possibly cold, again, alternating those, maybe on the back or using it on your forehead even could help. TENS units are not as common, but they are a possible choice. That's the transcutaneous electrical unit to help basically offset the pain sensations. It's an option. Acupressure as well. Water therapy. Some places offer water birth, but even just standing in the shower and letting the water hit you can be a really effective way to help manage pain. All the relaxation techniques. Oh, there's where it mentions effleurage, that light massage. And then any other sensory inputs that you can do that are positive things. Aromatherapy, imagery, breathing techniques, focal points, all these things to help distract and block that, pathway for the pain to reach your brain and to interpret it as pain. We can attempt to do that with all these positive sensory inputs. Cognitive method 2 would be biofeedback, hypnosis, and childbirth education. All these things have proven helpful as well. I mentioned that positioning is really important as well in changing your position, because the entire way through your pelvis, your baby has different spots where it might be needing a little more room, and then that can change from hour to hour. So changing your position can help with pain management, but also just for getting through and speeding labor a little bit. So it's good to have an arsenal of, suggestions. As a nurse, we want to be helping our patients whatever way we can. So we're going to encourage frequent position changes. This can relieve fatigue, but also kind of be encouraging, because if she's in one position and doesn't seem to be working, she could get easily discouraged and frustrated with that. It helps anytime you're changing a position. Usually it helps for a period of time, and of course it can improve circulation as well. Finding positions in an upright manner can be really good for bringing the baby down. It can increase the pelvic diameter, especially if we're in an upright squat position, or like a partial squat or modified squat. Can even help strengthen the uterine contraction, because, you know, with that extra gravity also pushing in the direction that you want to go, can help promoting the descent of the fetus, can help minimize discomfort and shorten the second stage of labor as well, which, remember, is the pushing stage, and can increase the incidence of perineal trauma. So it's also a good anatomic position for the physical birth of the baby. Okay, moving on to pharmacologic pain management. So these are all the drugs, right? Analgesia, of course, is alleviating a sensation of pain. That's the definition. In labor and delivery, we have opioid agonists and opioid agonist antagonists. These can cross the placenta, they can affect the fetus, and they can cause respiratory depression, central nervous system depression. A couple of these, this is not a comprehensive list, but a couple of them include fentanyl and Demerol. So again, here we're talking IV medicines. We give these earlier in the labor, not after a certain point, because we want to make sure that it is completely out of the mom's system before the baby's born, because it causes respiratory depression. We do not want respiratory depression when the baby is born, right? We want the baby to cry loudly, fully, clearing its lungs from all the fluid and beginning to have respiration on its own, right? So these are the things we're considering and watching closely. We always use the IV port closest to insertion, and it can be most effective during the peak of a contraction. And we don't normally give it intramuscularly. We pretty much always have, you know, an IV when the mom is in labor. If for some reason she needs it and doesn't have an IV yet, or maybe her IV is, you know, blown, then we could give it in the deltoid. I would be cautious of this because I want to have an IV to do, you know, before I'm giving any kind of medication, because I want to be able to provide intervention should the baby's heart rate crash. That would be a priority for me, but it is possible to give intramuscularly in the deltoid. In addition to the IV pain medicines, we also have local anesthesia. Pictured here is the pudendal nerve block. This would be better, say the mom didn't want to get the epidural, or she didn't have time to, but she's feeling or afraid of feeling a lot of perineal pain. This would be local anesthesia to be able to numb that area. She can't have IV medicine anymore as she's nearing delivery, because it would cross over the placenta and cause respiratory depression in the baby. So a pudendal nerve block is a possibility here. Other types are also the spinal anesthesia. It's another type of block. This is done mostly in C-sections where the mom doesn't already have a working epidural. The disadvantages for spinals are marked hypotension, impaired placental perfusion, and ineffective breathing patterns. But all of those can happen with epidurals as well. But with a spinal, you've given the medicine, it's one big bolus, and that's it. You know, there's no, you know, kind of going back from there. So other things that complications with spinals similar to an epidural are headache. If there was leakage of cerebrospinal fluid, then she might get a spinal headache and require a blood patch to fix that and basically seal that leak off, which would help the spinal headache. We're going to talk more about epidurals here as well. Okay, so epidurals and spinals, we're positioning in this sometimes side lying, sometimes hunching over your belly or a pillow to kind of poke your back out like a mad cat to open the spaces between the vertebrae. This can be more difficult if the patient is obese. Disadvantages with this are very similar to the spinal that we just talked about. Maternal hypotension decreases blood flow to the placenta, and that immediately affects the baby's heart rate. So we're watching this really closely. He could also, the provider, he or she could get a wet tap and accidentally puncture the spinal area with the cerebrospinal fluid and get a spinal headache. Other options used less commonly are combined spinal and epidural, also called a walking epidural. That's used less often. Practically in the hospital, once you get an epidural, you're pretty much bed bound. You cannot get up out of bed. It's not safe to do so, first of all. And also, oftentimes your legs are numb and heavy and you just wouldn't be able to walk on them. Oftentimes there is some fentanyl or morphine given through the epidural or spinal as well. So these opioids given that way. Now, one note about epidurals is that every epidural is different for each person, and even for the same person within each pregnancy, because the exact location of the epidural catheter could be different than it was before. It could be diffusing through that space differently than it was before. Maybe it's different medication even than the last epidural was for you. So it's very different, different areas of numbness for different women depending on their level of anesthesia. So some women will feel more pain vaginally, some will feel more pain up top at their fundus level. Some will maybe feel a hot spot where they can still feel their contractions in one specific spot on their belly. Different factors like that can really affect the way the epidural is working for that woman. Now, usually we can call anesthesia back to dose her more if she's having issues, sometimes even redo the epidural and try again. But I usually like to tell patients that just so they have a realistic expectation. It's not very common, I would say, for the epidural to not just numb the patient completely and then they don't feel anything until the baby's born, right? It's usually going to be that they can still have some discomfort and just to expect that possibility. Another interesting note is that this will decrease the pain of contractions significantly, but most people will still feel the pressure sensation, especially as the baby is crowning or, just getting very low in the pelvis. She's going to feel like the epidural is not working and it's just this intense pressure feeling. So that's normal. That is not something that the epidural can necessarily take away. So just a note there for patients as well. This is just a graphic of the area that the epidural is given. So epidural here is on the outside of the dura. It's epidura. The medication given here is, you can give a lot higher concentrations, and it is diffused throughout that space and absorbed much more slowly. Whereas with the spinal, on the other side of the dura, it is absorbed very quickly, And a smaller dose does the same thing that a very large dose does for an epidural. So just kind of some things to think about there. So side effects of anesthesia, we already mentioned these a couple of times, but just to reiterate, because it is very important and very, very common. The main thing we're looking for after an epidural or spinal procedure is sudden maternal hypotension. The medications can cause mom's blood pressure to drop dramatically. When this happens, as I mentioned before, the blood flow to the placenta drops very quickly, and you will see it in the baby's heart rate. So this transient alteration in fetal heart tones occurs, and we oftentimes will have to intervene to help support the mom's blood pressure and get the placenta perfusing again, as you would expect it to. So other possible complications are nausea and vomiting, especially with opioids, and the pruritus, the itching, intense itching are side effects of opioids. Now, nausea and vomiting also happens in transition. It's one of the common signs of transition. So it could be, a side effect of the opioids, or it could be just a natural physiologic response to labor. Anesthesia can also cause urinary retention. It also, with spinal and epidural anesthesia, she has no sensation of her full bladder. So we're placing a Foley to drain her bladder through the entire length of time that she's under anesthesia, and frequently assessing that it's actually working, right? That it didn't get clogged, anything like that. It can also cause an increase in maternal temperature. And as I mentioned before, inadequate pain relief is a possibility. It just might not work for her as well. And then the post-dural puncture headaches, also called spinal headaches, that we mentioned before as well. Okay, so we've talked about IV medicine. We've talked about blocks, epidurals and spinals, and pudendal blocks, right? Now we're talking about general anesthesia and nitrous oxide. So nitrous oxide is inhaled. Most of us are familiar with this because they use it oftentimes at the dentist. It can be effective in reducing the perception of pain. Of course, it's not as effective as like an epidural or spinal. It doesn't take it away completely. It's not even as effective as IV medicines, but it can definitely be much safer. Because the IV medicines, again, cause respiratory depression, and especially if used closer to delivery. So nitrous oxide can be used, closer to the baby's delivery because it has such a rapid onset and a rapid use in the body. It quickly is diminished in the body and the baby's body as well, okay? So it can cause a feeling of euphoria and decreased anxiety, and she can use it as needed. She can decide when she wants it. So it's a good, option for moms that maybe want to delay getting the epidural, or maybe don't want one at all and don't want IV medicines because of the risks of it as well, or maybe they don't like the way it makes them feel. So it can be a good option. Not all hospitals offer this. The hospital I work in does not, so it just depends. Okay, general anesthesia. This is a last resort. All of the anesthesia medicines cross the placenta, and they will affect the baby. So we use this only if the spinal or epidural is not working to be able to do the C-section, and for the mom to not be able to not feel pain. So we usually try the epidural or spinal first. And if that doesn't work, then we might have to do general anesthesia. Another time this might happen is if we just don't have time, right? It's a super emergency. We can get an IV pretty quickly, but we can't necessarily do the epidural and spinal quickly. So also just emergency situations might need general anesthesia. So this only happens in 10% of cesareans, And of course, the rate of C-sections is a lot less than vaginal delivery. So this is not 10% of pregnant patients. This is 10% of that small percentage of people that have C-sections. Okay. If obesity will make it much more difficult to intubate the patient, they have to be intubated if they get general anesthesia. And then there's also a risk of aspiration. So some of the nursing considerations for this are that during labor, we limit solid foods. We usually, once she's in active labor, we limit her to clear liquids. And then once she has an epidural, because that automatically makes her high risk at that point, a high risk labor, she's usually only allowed ice chips. Sometimes little sips here, or sometimes we'll try to flavor the ice with apple juice or something. But it's only ice chips after that point in case she has to go to surgery. So we're trying to limit the stomach contents to prevent aspiration. Once general anesthesia is administered, we deliver the baby as soon as possible to limit as much as we can the amount of general anesthesia crossing to the baby, because these babies are definitely born under the influence of anesthesia as well, and they might need to be intubated themselves in order to breathe until that wears off. We might need to give them Narcan to counteract the medicine that was given in anesthesia as well. Okay, the last thing, this practice question. The nurse should realize that the most common and potentially harmful maternal complication of epidural anesthesia would be severe postpartum headache, limited perception of bladder fullness, increased respiratory rate, or D, hypotension. So, looking at this question, I first want to read it very carefully, and I noticed a couple of things. The nurse should realize that, and then the word most is bolded, so most common, and then it's got another factor, and potentially harmful. It's a maternal complication of epidural anesthesia. So let's start down the list here. A is severe postpartum headache. And we have just learned that this is a risk of epidural anesthesia. So A could be a possibility. Looking at B, limited perception of bladder fullness. Yes, we also learned that this is not a complication necessarily though, but it's we could call it a side effect of epidural anesthesia. So it's a possibility, but I'm already leaning toward the headache as being worse because it's not really a complication and it's not necessarily potentially harmful. It is very common though. In fact, it's universal. So let's keep looking. C would be an increase in respiratory rate. No, that's not it, right? All the things we've heard about, the side effects are a decrease in respiratory rate as a result of all the medications that we've discussed. So this is just not it, right? And then D, hypotension. Yes, we have learned that epidural anesthesia can cause hypotension. So let's go back up and look at these three. So we're looking again at most common and potentially harmful. I've pretty much ruled out B, the bladder fullness, and C, the increase in respiratory rate. So I'm looking now between severe postpartum headache and hypotension. So the answer is going to be D, hypotension, because a severe postpartum headache is not more common than hypotension, first of all. Hypotension is very common with epidural procedures. And as I mentioned earlier in the lecture, it's one of the main things, if not the main thing we're looking for, the complication we're looking for when we administer epidural anesthesia. And it is the most potentially harmful. Okay, so the severe postpartum headache, the spinal headache, is inconvenient and painful. but it's not a long-term effect for the mom or the baby, because already the baby's born by this point too. We just determine that that is the cause, and she gets a blood patch, and then she, may have a little bit of a recovery, but it's not necessarily a potentially harmful situation. Hypotension is because of what it does to the placenta and to the baby. So hypotension, again, it decreases blood flow to the placenta, which of course decreases oxygen. We see it in a drop in the baby's heart rate. If this is not remedied and corrected, then it can even cause brain damage in the baby. So it's very lots of potential for harm there, and it is also very common. So we're going to say D is the answer. Now let's check our answer. And yes, that is the answer, which we just talked through all of that. So I hope this helped you some thinking through some of the considerations for pain management in labor.